Good morning, everyone. So, I'm here to talk about what one should necessarily know before starting their mixed journey. So, according to me, choosing the right patient is the most important aspect of starting your mixed journey. So, we all know that the best patients are mild to moderate open angle glaucomas, in whom that you need a pressure reduction of let's say 10 millimeters or so. So the target IOPs should be somewhere around mid to high teens, and also specifically MIGS is designed for those patients who have difficulty in taking their medications, who have side effects or compliance issues. However, contraindications of MIGS are also there. It cannot be done in juvenile open angle glaucomas, all forms of secondary glaucomas. It is not, all the devices that are available for MIGS are not licensed to be used in primary angle closure glaucoma. The next most important thing would be adequate pre-op assessment. And I cannot emphasize enough that when we say that MIGS applies to mild to moderate open angle glaucoma, we mean that the staging is done only on the basis of visual fields and not on the basis of how high the IOP was or how many anti-glaucoma medications the patient was on. Also, it's important to remember the fact that the inability of MIGS to bring down the pressures to very low teens also limits its use in advanced glaucomas and normal tension glaucomas, at least the MIGS procedures that are available in India. Also, in the pre op assessment, be very sure to rule out any corneal opacities, haziness. Ensure that you have a very crisp view of the angle. The angle is devoid of any peripheral anterior synechiae. Also, so now I think I have changed my practice from doing MIGS post cataract surgery to doing MIGS any form before the cataract surgery, because instances like these also happen where at the end of cataract surgery you encounter corneal edema and there could be hyphema with your attempt on starting the MIGS, and then the angle view is absolutely zero and you cannot proceed, and there are times that you may need to abandon the MIGS procedure. Also, take a very good history of patients being on blood thinners and take measures intraoperatively accordingly. It's also very important to familiarize yourself with the correct positioning of MIGS patients. So, for MIGS, the surgeon is sitting temporally. The patient's head is turned 35 to 45 degrees away from the surgeon, and the microscope is tilted 35 to 40 degrees towards the surgeon. The kind of view that you want to get is the en-face view, wherein you have three distinguished bands of trabecular meshwork, scleral spur, and ciliary body band. But when the position of the patient is not adequate or the angulation of the microscope is not accurate, you may have trabecular meshwork, scleral spur, and ciliary body band blend with each other, and these three structures, they become indistinguishable from each other. So this is the kind of view that you get when the patient's head is not tilted enough or the microscope is not tilted enough. This is called an anti-MIGS stance. But you can notice that as soon as the patient's head is tilted further away, which is usually the case to position them properly, the angle becomes very clearly visible with all the three structures very distinguishable. Also, proper understanding of the angle structures is very important. Over here, you can see that the red arrow points at the level of the trabecular meshwork and the black arrow points at the level of the root of the iris, so the ciliary body band. This video is being played with permission from the primary surgeon who wishes to be anonymous. And you can see that the bang procedure is being performed at the level of the root of the iris, which probably explains the bleeding in the cyclodialysis cleft that ended up happening. So the proper understanding of angle structures is something one has to be familiar with before starting their MIGS journey. Also, make sure that you have very clear corneal incisions, because you don't want bloody incisions which enter the anterior chamber and obscure your view of the angle. Use very good cohesive viscoelastics. I prefer to use sodium hyaluronate 1.4 because it deepens the anterior chamber, it keeps it stable. No matter how many times you go in and out, the anterior chamber does not fluctuate. It gives you a brilliant view of the angle, and also see how well it fits on top of the cornea. It doesn't flow out, it just sits there. That's how viscous it is. It also limits the reflux bleeding that may happen during mixed procedures. So you can see the brilliant view of the angle that it gives. And also avoid tendency to fill the anterior chamber with viscoelastic, lest you may have problems like this iris prolapse. It becomes a messy surgery thereafter. In the end, don't overpromise. Always tell the patients that we will combine this with your cataract surgery, and that will probably lengthen the time of your phaco. We are trying to get you off a few drops or reduce the IOP, the intraocular pressure post-operatively for you. I describe it to my patients as a way to open the natural drainage system of the eye, like unclogging a sink drain. Also, as far as the post operative medications are concerned, the regimen remains the same as cataract surgeries, but my method would be to stop all anti glaucoma medications right after surgery, because you want to see how much of IOP reduction the surgery per se is bringing. And since these patients, they have good nerve reserve, they are mild to moderate open angle glaucomas, they can it's okay to experiment in them over a month with a stepwise increment in anti-glaucoma medications if required. Thank you so much.
Thank you, Dr. Sahebaan, for a nice presentation. I just wanted to know how does these implants work in an eye which has had an SLT or an ALT?
So you can't, ma'am. They're first of all, they have the implants you're talking about, the eye stent implant. No, so I wouldn't suggest it in the area of SLT. But then, yes, of course, if there are areas which are spared of the SLT, I think that's the advantage of the stent, because it's so less invasive. It requires only 2 clock hours to be implanted. You have the whole trabecular meshwork to play with. But on the area of the treated SLT, it should not be implanted.
But very difficult to identify, yes.
Also,
Yes.
that.
Yeah, because once you're done, you can't. You usually do either 180 degrees or maybe 360, so it's difficult to know. There'll be no skip areas.
But
Yeah.
there are studies that have actually studied eye stent on previously treated eyes with SLT, but they weren't very specific on whether that same treatment area was where the implant was placed or other areas. I'm assuming it is other areas. It doesn't really make sense, because if you're delivering laser, you're actually also damaging,
Scarring.
the ability of the Schlemm's canal to open up beyond that.
I think every surgeon has their preference of doing the SLT. Usually they do it
Yeah,
180
yeah, 180,
inferiorly.
yes.
So we know that this area we have done SLTs. Try to skip that area and place the eye stent.
And when you are deciding that you are going to put an eye stent, it is usually you start with one, or do you prepare sometimes to put multiple? No.
No, the generation 1 has got one implant in the injector. Generation 2, the eye stent inject, has got two implants in the same injector, which will go in the same patient, 2 clock hours apart. So it's more effective, the generation 2, but yeah, it's more costly also. Eye stent Gen 1 also works very well. I've done almost 12 now, and it's working very well.
And one last question before we wind up. So, what is the biggest challenge that one can have, and biggest problem which one can land in after?
See, the biggest challenges I think are mental block, and the counseling of the patient is very important. Counseling of the patient, telling them why we are doing this and what is the next step if this doesn't work. Trabeculectomy, which is a more invasive surgery where we have to put another incision, we have to put sutures. So show them the future. If your glaucoma progresses, this is what we'll have to do. And tell them about, because you are in the initial stages of glaucoma, you have mild to moderate glaucomas, this is, and you are undergoing a cataract surgery, this is what we can do to slow down the progression, so that in your lifetime you don't get a trab or a tube done. You don't land up with a trab or a tube. So counseling of patient in that way, the patient understands, and tell them that we are already going in for the cataract surgery. It's hardly a 5 minute 7 minute procedure, that and the recovery is very quick. The worst thing that can happen during the surgery is you don't implant it properly, right? So with generation 1, if it is under implanted, if it is not implanted properly, you go hold it back, and just besides where you had planned initially, implant it. It's plain and simple.
You
not
can pick it up and reimplant
you
it,
can
ma'am.
easily pick it
I
up and
think for the
reimplant.
first few surgeries, it's a good idea to keep a backup.
No,
But yes, over implantations and under implantations are a known, learning curve challenge that one can have.
yeah, usually with the generation 1 you won't have an over implantation. You can have an under implantation but not an over implantation. But like Saiba told, over implantation can happen with generation 2. They inject, and if that happens, that's the worst thing that can happen. But again, it will not cause any harm. You have to let go of the implant. All right, it's so small, it's so tiny, it'll go in the suprachoroidal supraciliary space, and it's not going to cause any harm. The they will provide a backup generation 1 with a generation 2. So if one implant is over implanted, you have lost that implant, you can implant a generation 1 instead of it. So that's the worst thing that can happen.
Pupil before you put the.
I used to, but now I've stopped doing it.
So it suppose it can't go beyond the, I mean, behind the iris. It won't get lost.
No, no. Yeah, but initially, yes, to elevate your apprehensions, put pilocarpine, constrict the pupil. My first case, I sent inject. The first implant was under implanted. I picked it up with a microaccess forceps, brought it out, thread it in the injector, and
Went
implanted.
beside the lens.
No,
the le-
no, it was in the angle itself, but under implanted. So you have to check it after the surgery. Those are the steps that has to be done.
I think it's nice to tap it once you've injected it to establish that it's sitting well. Yeah, if required, you can even push it a little in further to make sure that it's not under implanted.
Also, because you have a very cohesive viscoelastic, the implant is never really free floating like that. The kind of movements that you find with just HPMC. So if it's there, it just falls right there only, that you can rethread and put it back.